Hello everyone and welcome to this week's NDARC webinar. I'm Alice Havard, a researcher at NDARC, and it's my pleasure to be hosting the webinar today. I would like to begin by acknowledging the Bidjigal people as the traditional custodians of the lands that I'm joining from today at NDARC's new home in the Health Translation Hub in Randwick. I would like to acknowledge the traditional owners of country throughout Australia, noting that our speakers and audience are joining from many different locations across the country. We pay our respects to elders past and present and extend that respect to any First Nations people joining the webinar today. It's now my pleasure to introduce today's speaker, Grace Burton-McKeach. Grace is a research assistant in the Viral Hepatitis Clinical Research Program at the Kirby Institute at UNSW. Grace's research uses qualitative methods and is focused on improving care for people affected by hepatitis C. In today's webinar, Grace will be presenting findings from her qualitative study exploring Australian healthcare provider perspective on treating hepatitis C in pregnancy, including their views on clinical management, barriers to implementation, and the design of integrated care models. We're lucky to have two other members of the project team joining as our expert panelists. So we have Dr. Alison Marshall, who leads the project. She's a senior lecturer with appointments in both the Viral Hepatitis Clinical Research Program at the Kirby and in UNSW's Centre for Social Research in Health. Alison is an expert in mixed methods research, focusing on breaking down barriers to hepatitis C care for people who inject drugs. And we also have Dr. Danielle Russell, also from the Viral Hepatitis Clinical Research Program at the Kirby Institute. She's a qualitative researcher and a community representative with lived experience of drug use and opioid agonist treatment. Danielle is conducting a related stream of work attached to this project, in which she's interviewing women who use drugs about their perceptions of optimal placement of hepatitis C prenatal care. So Grace, Alison, and Danielle will take questions from the audience after the presentation. You can log questions for them using the Q&A function at the bottom of your Zoom window. And I welcome you, Grace, now to turn on your mic and camera, and I'll hand over to you.
Great, thank you so much, Alice, and NDARC, of course, for having me this afternoon, and thanks everybody too for making time to join this webinar. So as Alice said, my name is Grace, and today I'll be presenting a talk called Australian Healthcare Provider Perspectives on Managing Hepatitis C Treatment During Pregnancy, Current Practices and Pathways Forward. I'd like to echo Alice's acknowledgement and pay my respect to the Bidjigal and Wongal people, the traditional custodians of the unceded land where the majority of this work took place, both at the Kirby Institute and the Sydney Olympic Park area where I live. I'd also like to acknowledge all the collaborators and funders for this study so far, including all the co-investigators and the health systems research funding, as well as the BUMPC community panel. So this is a panel made up of women with lived experience of hepatitis C care during pregnancy, and their insights have been absolutely crucial to informing data collection and our ongoing analysis. I have nothing to disclose this afternoon. And so the aims of my talk today are to share updates on the current state of treating hepatitis C in pregnancy, and inform you on findings from the Bridging Unified Management of Pregnancy Care and Hepatitis C. And this is the BUMPC study. So this talk will include findings on how pregnant people with hepatitis C and their infants are currently managed in clinical settings, the challenges associated with current models of care, what providers think about prescribing hepatitis C treatment in pregnancy, and who providers think should be responsible for managing delivering treatment in pregnancy. So moving into the background now, in 2019, between 24,000 and 33,000 women of childbearing age had hepatitis C in Australia. It is estimated that women of childbearing age who inject drugs are 53% less likely than women aged 45 years and above to receive hepatitis C treatment. Likely reasons for this Treatment disparity include a reluctance to engage in care due to stigma, fear of losing custody of their children if they have children, and a lack of services that prioritize women of childbearing ages and women with children's needs. One suggestion for overcoming this disparity in care is to treat women in pregnancy who have hepatitis C. And this is because while it doesn't necessarily directly address these barriers that I've just mentioned, women do tend to be more engaged in care when they are pregnant. So therefore, that provides us more opportunities to engage them in treatment. However, at the moment, pregnant people who are diagnosed with hepatitis C in pregnancy must wait until they have finished breast or chest feeding before they can begin their treatment. And this poses challenges to linking parents and their children back into care, including hepatitis C testing, then the ongoing initiation of treatment. And I'll go into this further a bit later in the study, but when mothers can be breastfeeding or chest feeding for variable amounts of time between 12 and 18 months. So yes, that does pose challenges to providers who then have to contact these families again, and lots of things can happen in that time. Increasingly, evidence does suggest that DAA treatment is safe and effective during the third trimester. So several studies have shown that mothers who take DAAs in pregnancy achieve sustained virologic response, that hepatitis C is not transmitted to their infants during delivery, and infants up to 1 year old experience no adverse outcomes. Promisingly, we are awaiting the findings from a trial conducted here in Australia. However, I did recently find out that this trial was closed early because they were finding recruitment quite challenging and they had run out of funding, but hopefully we get to see some results either way. Treating people in pregnancy may eliminate the risk of vertical transmission during delivery, prevent transmission to others, mitigate gendered inequities in hepatitis C outcomes. And indeed, there are some places, namely the USA, where hepatitis C treatment during pregnancy is permitted on a case-by-case basis. So it is likely Australia is to follow suit, especially as the evidence continues to grow. The aim of the BUMP-C study is to qualitatively investigate current hepatitis C care pathways for pregnant people and healthcare provider acceptability of integrating hepatitis C treatment and pregnancy care in Australia. To achieve these aims, we qualitatively interviewed healthcare providers, and to be eligible, healthcare providers had to have experience caring for pregnant people with hepatitis C or caring for pregnant people at risk of acquiring hepatitis C. These interviews were held on Teams and, of course, audio recorded and transcribed. And coding was informed by the Health Equity Implementation Framework, which I'll describe shortly. And we use iterative characterization, a qualitative analysis method, to generate themes and the final results for this study. So as promised, this is the Health Equity Implementation Framework. And this framework has 4 main domains. So we have context in blue, recipient factors in yellow, orange, and pink, innovation factors in green, and then clinical encounters, the box there. For the purpose of this presentation, I'll be just speaking to 3 domains: inner context, innovation factors, and recipient factors, particularly those related to providers. And that's because the most significant data were captured by these domains. All right, getting into the results. So in total, we interviewed 30 healthcare providers from a range of different specialties, as shown in the table there. And just to note, in terms of how we categorized specialties, we had to keep it quite broad just to protect the participants' confidentiality. As you might imagine, the perinatal hepatitis C care space in Australia is pretty small. So to try and address this, for example, we grouped maternal fetal medicine specialists into obstetrics, neonatologists into pediatricians. The median number of years our healthcare providers had spent practicing was 25, so it was very experienced and senior level cohort. Most providers worked in New South Wales, and unfortunately, we were unable to interview anybody from Tasmania, but every other state was represented. And just before I move into the actual results, I'll note that the quotes that are used here have just been tagged with a participant number and the provider's specialty, again, to protect their confidentiality. Right, so inner context, current pathways. Here I will highlight the different testing and referral pathways for pregnant clients and their infants that were described by providers in interviews. Starting with pregnant clients in this pink box, most providers did say that all pregnant women should receive hepatitis C antibody testing as part of their standard antenatal screening alongside other tests like hepatitis B and HIV. Some providers did also note that they would recommend and perform additional testing later on in the pregnancy if that client did have continued exposure to risk factors like injection drug use. And so you might notice here in this box too that the number of participants doesn't quite add up to 30. And I promise I can count. It's just the nature of qualitative research. Sometimes in interviews, participants don't always speak to these exact categories or don't get to answer the question at all. So yes, this is on purpose, not an accident. Thinking now about pregnant clients who test positive for hepatitis C, most providers said that they should be referred to an infectious disease physician or other specialist. An important point to say here is that most of the specialists that I did speak to said that they often receive referrals based on hepatitis C antibody tests alone. And so for people who might not be too familiar with hepatitis C testing, to know if somebody has active hepatitis C infection, you have to have an RNA test. So if somebody has an antibody test only, that could mean that they've just had previous exposure to the hepatitis C virus and had treatment or cleared it themselves. It doesn't mean that they actively have infection. So the fact that specialists still receive referrals, on tests based on antibodies alone just shows, especially among antenatal care providers, the lack of understanding about hepatitis C testing and hepatitis C in general. Thinking now about the infants born to clients who test positive for hepatitis C in pregnancy, you can see there's a bit more variability in terms of who is managing infant follow-up, and as well as a bit more uncertainty about who is the right person to be managing it. If you look down at the antibody and RNA screening sections too, you'll see particularly in RNA screening, there is a lot of variability in when testing takes place. For example, we've got 5 different times participants reported. I'll speak to this more now. So on this slide, I've got the pathways that providers shared to us next to a management algorithm published by the Australasian Society for Infectious Diseases. And so, as you can see, for the most part, providers do perform testing within the recommended guidelines, for example, doing antibody screening between 12 and 18 months. For providers who operated outside of these guidelines, so for example, performing RNA testing whenever they see the infant, they said that they were doing this to try and prevent loss to follow-up. They felt that it was better to have some test result, even if it might not be too accurate. For example, if that RNA test is done prior to 3 months of age, it can be a little less sensitive and specific. So they felt, that it's better to have some test result than no test result at all. And the last point to make on this slide is that even though we have these high-level, national-level guidelines from ACID and other colleges and state health organizations, clearly hospitals have their own recommendations for doing things, or providers it's up to them to decide what the best course of action is. And this is even evident in local operating procedures. So for example, we have this from a local operating procedure from a hospital who will remain unnamed, but it says infants need testing with RNA at 2 and 6 months of age. This is a bit different, obviously, to the ACID ones. So I'm not a clinician, and maybe there's a clinician joining us here today who could explain that for us. But yeah, it's just one of the interesting findings so far of this study. Okay, so thinking about now the successes and challenges of these pathways. To be frank, there weren't too many successes that providers could speak to. There was a bit of a consensus on the fact that it was a good thing that hepatitis C was part of that standard antenatal screen. But in my opinion, I think this is a bit of a low bar and really just shows the extent that providers felt these pathways were inadequate. So for the most part, providers did describe the perinatal testing and management of pregnant clients with or at risk of hepatitis C as ad hoc and fragmented. When care was seen as going well, providers felt it was serendipitous rather than deliberate. So, as participant 2 explains here, I think there are some systemic barriers for women in that they get seen by multiple different teams. And this fact of being seen by multiple different teams is really a key challenge that came out of interviews with providers, because what happens is that you have the antenatal care team, the midwife and the obstetrician taking care of the client and their pregnancy. And then if they're found to have hepatitis C, then they get that aspect of their care gets passed on to the infectious disease physician. And with all this care being separated, the consequence is that no one is looking after the overall well-being and giving holistic care to the person who's pregnant and with hepatitis C. And then that is what really leads to things getting lost or things being missed. So similarly, pathways were seen as poorly developed and unable to facilitate the long-term engagement. Excuse me. Long-term engagement of clients necessary to be able to offer treatment postpartum. And these pathways were perceived as especially likely to break down when child protection services became involved in families' affairs, when birth parents no longer had custody of their infants. And this is really illustrated by participant 18, who says, the cohort that I see, we really struggle with loss to follow-up. Trying to make sure that children are appropriately tested, especially when they've moved caregiver, is often very difficult. I've got kids who are in their 5th placement and their history is just gone. Many of the birthing parents coming into the program are struggling with their own things, and making an appointment 18 months in advance just doesn't work. So the challenges of delivering perinatal hepatitis C care, I think, undoubtedly contributed to why most providers felt that being able to offer treatment in the 3rd trimester is a good idea. However, who should be responsible for delivering this treatment and what care models should look like was something that was very contested among providers. So some providers thought that GPs were best placed to manage and deliver hepatitis C treatment in pregnancy. There were several reasons for this. A, because they were seen to have the best relationship with the client. B, GPs have familiarity both with hepatitis C care and antenatal care. And C, they were seen to have the capacity to provide more continuity of care than other specialists. So participant 7, the GP, says, involving other specialists sometimes just confuses everything. If I involved gastro, they'll be like, what? But she's pregnant. Or if I involve the obstetrician, they'll be like, oh, it's hepatitis C. I don't know. But on the other hand, many providers did think that this was more of a specialist discussion, that this was outside of GP's expertise. So a gastroenterologist said that although GPs have really engaged with hepatitis C adults and also manage a lot of pregnancies, this is an unusual situation, and I think it's more of a specialist discussion. Some providers thought that addiction medicine specialists were best placed because they likely have the most experience working with people who use substances, as well as managing bloodborne viruses. So participant 28, an addiction medicine specialist, says that this managing hepatitis C in pregnancy is a reasonable component of their role. But we have some other addiction medicine specialists like participant 5 that thinks that treatment in a pregnant person was not their role and that it should be initiated by an infectious disease specialist. Despite addiction medicine specialists having the knowledge base and a degree of comfort with people who use substances, They think their capacity would be the limiting factor to managing treatment in pregnancy. Many providers did think that obstetricians should be responsible for providing hepatitis C care and treatment because they were the ones who were going to see the pregnant clients the most. However, most providers noted that this was probably an ideal situation and unlikely to happen because hepatitis C treatment was seen as beyond obstetrician scopes of practice and because they already have overwhelming workloads. Despite this, one infectious disease physician says that even though obstetricians have got so much going on already, integration should not be that challenging because DAAs are relatively simple to prescribe and have limited side effects. But an obstetrician, they say, even though it would be ideal if it was integrated into maternity services, they simply do not have enough time to add an extra service to their workload. And even if the workforce was expanded, hepatitis C treatment would not be their priority. Overall, providers did seem most in favour of infectious disease physicians managing antenatal treatment, especially in the form of shared care models. Some reasons why participants thought that infectious disease physicians were most placed is one, because they were typically already involved in the care cascade, often receiving referrals for people who test positive for hepatitis C, and also because they were seen to have a more public health approach to their care and a more assertive model of care that would better meet the needs of people who use substances. A pediatrician here says that joint care models work best because by working together, infectious disease physicians and obstetricians can fill in each other's knowledge gaps. And this model did seem mostly aligned with providers' comfortability of prescribing treatment. And I'll get into that now in recipient factors. So of all the infectious disease physicians that we interviewed, all of them said that they would be comfortable prescribing treatment to pregnant clients. However, there is a bit of nuance regarding this point in that although they were comfortable prescribing it, they didn't necessarily feel comfortable recommending it at this stage. So participant 25 says, I think if the patient is keen for treatment, I would provide it in the 3rd trimester, but I'm not quite sure that I would say I recommend treatment to you at this stage. And the main reason why infectious disease and other specialists were hesitant to recommend treatment is because they wanted the support of obstetricians. They wanted obstetricians to be taking the lead and saying that this was an important thing to do. And this is summarized nicely by participant 19, who says, the main fear of people outside of pregnancy is that we're going to do something terrible to the child or the mother, right? If the obstetricians ultimately are saying, we think this is safe and it's the priority now, I think that gives the rest of us a lot more confidence. Now, the challenge with this hope of obstetricians providing that support that specialists wanted is that most of the antenatal care providers that were interviewed seemed reluctant to offer this support. They felt that there was not enough longitudinal data or big enough trials that really supported the safety of DAAs in children. So one midwife that we interviewed said, everyone thinks 3rd trimester is safe, but is it? I mean, the baby's brain is still developing and it's the most critical time for brain development. For them to feel more comfortable offering treatment, you said there needs to be much larger studies and also longitudinal studies. Similarly, participant 13 says that with the current state of evidence, these clinical trials on average containing about 10 participants, they said that busy clinicians won't even appreciate that evidence. They want bigger phase 3 or phase 4 trials before they even consider it. In saying this, providers who had extensive experience working with people who use substances did seem more comfortable with the idea of prescribing DAAs in pregnancy, regardless of their specialty, compared to providers who had less experience. So, for example, participant 12 says, I'm an obstetrician with a particular focus in substance use in pregnancy, and I do a few things outside the square. So I might be a little bit more open to prescribing DAAs in pregnancy than somebody else. And some other reasons why providers who had more experience working with people who use substances could be that they have a better appreciation for the barriers to care that people who use substances face. I think they tended to understand that healthcare systems are really not set up to meet the needs of people who use substances. Also, these providers seem to be more familiar with DAAs. They've usually had experience prescribing them themselves, so they've seen firsthand how effective they are and how few side effects they cause. And also, I think they perceive hepatitis C treatment as their core business. And so a few quotes to illustrate these points. Participant 18 says, I think sometimes there's just an assumption that people will have had pregnancy care. And if someone walks in late in labour, as they often do, people like midwives don't always think to take a serology. With these women, you need to make every engagement count, and you need to get as much as you can from each engagement because you might not get another one. Participant 19 says, I think what happens is that when you are dealing with a cohort where Hep C is such a common comorbidity, it becomes your core business. I can sort of understand the perspectives of those outside where it would be relatively uncommon. Just saying maybe I'm doing everything else and Hep C can wait. Okay, into the discussion now. This is the first qualitative study to explore the implementation of antenatal hepatitis C treatment in Australia. The interviews really highlighted the fragmented care pathways that likely prevent clients and their infants from progressing along the care cascade. The interviews highlight discordant views among healthcare providers regarding who should deliver treatment in pregnancy. And infectious disease physicians and providers who work with people who use substances did seem more open to prescribing DAAs in pregnancy than other providers. There have been some other studies conducted overseas that report similar findings about integrating antenatal hepatitis C treatment. For example, antenatal providers share similar concerns regarding the lack of long-term safety data. I've got this quote here from one of these studies in the US, but I feel like this could easily have come from one of the antenatal care providers in our study. This maternal fetal medicine specialist says, we need data on fetal long-term outcomes, as well as evaluation of fetal growth. I don't think we have robust enough numbers to say that this does not harm and does not cause long-term neurological outcomes for these kids. Providers in these studies have also felt that their limited understanding of hepatitis C treatment options and the lack of guidelines pose barriers to implementation. And so just speaking to that lack of understanding of hepatitis C treatment options, this was particularly prevalent among antenatal healthcare providers that we interviewed. For example, not knowing the difference between antibody and RNA testing, as well as not being familiar with updates to hepatitis C treatment and just how advanced it is nowadays. And talking to the lack of guidelines as well, I realized I didn't speak too much about that in the results, but this was something that providers said posed a barrier. So without supportive guidelines that are really directive on who is eligible for treatment, who should be involved in the care of a person with hepatitis C, it's really hard for them to feel confident that they're doing the right thing by offering treatment. Lucky for us, there has recently been an audit conducted in Melbourne of a tertiary maternity hospital. This audit was of the antenatal hepatitis C care cascade for pregnant people and their infants, and the results really quantify the extent of the fragmentation that I described right at the beginning. So in their study, they found that 20% of pregnant women with active hepatitis C were never referred to a specialist, either antenatally or postpartum. 50% of these women with active infection had 7 or more antenatal visits. So that just really shows the number of missed opportunities there were for, at the very least, some sort of referral. Of all the infants born to mothers with active hepatitis C, only 29% received an appropriately timed test, and 61% did not receive any testing at all. thinking about the reluctance to take on DAA prescribing is not something that is new in the hepatitis C space. I think, yeah, researchers have shown this for quite a while now. There's a number of studies that illustrate how primary care providers and even some addiction medicine specialists don't think hepatitis C is part of their core business, and therefore they don't think it's their role to take on hepatitis C treatment. Similarly, literature regarding opioid agonist therapy shows that primary care providers can be hesitant to become methadone and buprenorphine prescribers. And then with antenatal care providers, there have been some studies that report them being reluctant to accept new responsibilities related to oral health and sexual health. Just a few examples there. And so just quickly, this is a bit of what my take is. At the end of the day, these disjointed systems and the reluctance to assume responsibility for managing antenatal hepatitis C care is undermining the quality of care pregnant people with hepatitis C and their infants are receiving. In an ideal world, we need no wrong door approaches to overcome this challenge. And ideally, clients should be able to receive their hepatitis C treatment from their most trusted providers. But of course, to do this, providers need to be on the same page. And this is one of the core challenges I think that has been raised from our study, is that how do we overcome these silos that are clearly affecting pregnant people when they get infections and pregnant people who use substances. And as participant 9 says, but you still have the ongoing issue of is it our role and do we have the skills to do this? The design of new models of care must be led by people with lived experience. And while this is, of course, always important, I think this is especially the case based on the findings from this study. So, for example, in the client interview so far, some preliminary findings suggest that most clients would prefer their hepatitis C and antenatal care to be kept as separate as possible. And this is obviously quite distinct from what the providers were saying. They were really emphasizing joint care models, integrating care as much as possible. So how we really reconcile this challenge is an important next step for our study. Okay, and I'll just briefly speak to some limitations of the study. So the health equity implementation framework was something that we applied later on in the study. It didn't inform our question guide, for example. We brought it in when we started doing the analysis. So that sort of limits how applicable our data was to that framework. If we had used it to inform our interview guide, for example, then definitely providers would have been able to speak to more parts of the framework. Few providers were from WA, Queensland, and of course none were from Tasmania. So our results may be a little more reflective of New South Wales and Victoria than other contexts. And then lastly, providers in senior management positions seemed a little less willing to be candid during interviews. And this is just my personal reflection, but oftentimes people in these clinical director roles seem to have quite a different stance on the current situation. So, for example, one participant told me that the risk of loss to follow-up was a theoretical risk, and that even if a person was lost to follow-up, it wasn't such a big deal because we could just engage them in care again later on it. Offer them treatment then. But I think this assumption was really something that was debunked, and what other providers really fought against and wanted me to take away from the interview is that we only have a small window of opportunity to make sure that people get the treatment that they want. And so, in conclusion, findings from this study illustrate the fragmented care pathways for perinatal hepatitis C care and highlight the different views among healthcare providers regarding who should deliver treatment and what effective care models should look like. The results of our study have local and international implications, especially in places where antenatal treatment is already permitted, and in contexts where the rates of hepatitis C of childbearing age have been increasing. So, for example, in the USA and in Canada. Looking ahead, it will be important for us to analyse data related to structural barriers to implementing treatment, for example, how workforce shortages might affect integration, as well as the challenge of changing medicine labels. So if we want providers to feel confident prescribing it, then it would be helpful if DAAs themselves didn't have any contraindications about pregnancy, but this is much easier said than done, so I've heard. And to compare provider perspectives with those who have lived experience of antenatal hepatitis C care will be crucial. And this is for any clinicians or people who work in health services in the room. Here are some key takeaways that I hope you can gather from the data that I've shared today. It would be great if you can ensure that your hospital or service has clear guidelines or procedures in place so that clinicians know when to test and who to refer to, and also to identify champions who could ensure pregnant people and their infants are referred to the best place, and also make sure that these people have the opportunity to receive treatment when they do become eligible and not lost into the ether. But thank you very much, and I'm looking forward to the panel discussion and welcome your questions.
Thank you, Grace. That was a great presentation and really good and important to have these insights now so that health systems have an opportunity to iron out these issues before hepatitis C treatment in pregnancy becomes a reality. I'm now going to invite Alison and Danielle to turn on your cameras. Welcome both. And I will put a question to you, but just to let the audience know and remind you that the Q&A function at the bottom of your screen is available there to take your questions. So please pop those in. And in the meantime, I'll be asking Alison and Danielle for their reflections on what Grace has just presented. I wonder, Alison, if you might like to start.
Yeah, sure. Thanks also to NDARC for hosting this session. So I think just briefly, as you can see with Grace's interviews, there's been a lot of information that's come out of it at once because you're working obviously across many different aspects of the healthcare system. And I think as part of the discussion points that Grace mentioned, this isn't necessarily new in that you have different specialties sort of, I guess, having some discussions amongst each other as to who will take this on and who feels comfortable taking this on. I mean, we saw something very similar with work that we did previously, speaking to people who were drug and alcohol specialists about doing hepatitis C prescribing and their comfort level and willingness to engage in that space. And initially there was, some hesitation and resistance, but there's always those waves where people feel a little bit uncomfortable, and then as more people do it and more evidence comes out, there's more comfort and ease. I think just in relation to also the last slide that Grace was speaking to, but I know also that came out of some of the interviews that Danielle's been doing in parallel with the clients. I think what has been of interest to us, and Danielle, it would be great if you could speak a little bit to this, is just that we've kind of come across in interviews or conferences where Grace has presented where it's, sort of commentary on Grace's presentation has been, well, there's treatment available and women will just show up to the appointments, and we don't really see this as being any kind of issue, or we're not foreseeing any sort of issue. But, Danielle's interviews would suggest that there's still, and rightfully so, some hesitation among some women with substance use challenges of having these open discussions with their healthcare providers about both their substance use during pregnancy and postpartum, and the difficulty of initiating some of these conversations. And in some circumstances, people really wanting to keep the Hep C component of their lives separate from their pregnancy care. So Danielle, I don't know if you wanted to mention some of the things that are also coming out of your interviews, because sometimes they conflict with what some of the healthcare providers are recommending in Grace's interviews.
Yeah, so a great presentation, Grace, too. But I think some of the things that stood out when I've listened to Grace talk about the provider interviews is the providers seem to have this impression that offering more people and more more various providers, like wraparound care, is just a general good thing, and it's experienced as positive. But some of the women that I interviewed, they experienced it as like very disempowering and kind of overwhelming, because it's like and that stood out, as well as many of the people I spoke to were very isolated and lacked support, so they were often doing things alone. And then they would have like panels of all these like very educated doctors just like kind of rapid fire information at them, and they felt outnumbered, and just it was a lot, as opposed to having a one-on-one. Might have been a little bit more appropriate for someone who's maybe feeling overwhelmed and nervous and scared and needs information, and needs to be comfortable to ask questions. And the other thing that was striking was, I think one participant even said it directly: Hep C stuff, baby stuff. Like, because I asked more follow-up questions, and as I was asking him, she just said, like, look, hey, Hep C stuff, baby stuff, as far apart as possible, like, keep them separate. And that was quite a few people said that, because they seem to believe, and based on their past experience, that it would be very stigmatizing. The Hep C is like a big red flag, like injection drug user, and they don't want that associated with something they're trying to keep as separate from all of those troubles as possible. And it's like they associate safety with separation of all that, even if sometimes it didn't seem like it would be possible, which is like to like disentangle those like intersecting identities for people. But as much as possible, that was the desire. So I think, like Grace was saying, it's just finding a way to reconcile these kind of discordant, I don't know, expectations and needs and experiences. It isn't going to be something that's just simple, because like also was saying too, oftentimes it is presented as if like, okay, well, of course, women want to show that they're good mothers, and this is one of the ways that they would signal that, and so they'll just do it. And it's like, well, is it going to create problems for them? Is it going to hurt them? Because a lot of the stories I heard were quite harrowing and not very nice, and no one should have to go through those type of things. So yeah.
Yeah, I mean, that's really interesting. It's such a challenge to reconcile those two things. Were there areas where the women you've interviewed, Danielle, have agreed with some of the messages that have come through the interviews that Grace has done with healthcare providers?
Yes, yeah. Some people said, some people were very ambivalent, like it doesn't matter which doctor it is. But they would often say, like, yeah, if they could get it at the same time. There was less concern about, so long as it was safe. I think that was the response was usually like, so long as the medication is safe and a doctor says it's safe and it's not going to hurt mom or baby, to have it integrated into pregnancy care. Some women were like, yeah, great. And I think it was, we need to analyze the data a little closer to see. But I think that some of the women, I want to know like their ages, because maybe they're younger, had like less history of like trauma in medical spaces too. I'm curious, because it definitely was two separate camps, I guess, if you will, of like it's okay and yeah, ambivalent, and then like a no camp. So
yeah, okay. So even within the group of women, there's not one story or preference. Okay, challenging stuff, hey? Okay, we might go to the audience questions. So we only have a couple there so far, so please do feel free to pop more in. But there's one here, Grace, from Alex Willing, about the use of RNA tests and the reason for it being better than no test at all. So do you know if this was because clinicians only had access to RNA testing, or confusion around the difference between antibody and RNA testing?
Thanks, Alex. So that was in reference to infant testing. And so the ACID guidelines, they're saying we should do RNA testing at 3 months of age if the parent in particular is very concerned. Otherwise, let's just wait until 12 months for an antibody. So you can't do an antibody before 12 months because it will pick up on the mother's antibody. And then related to whether it wasn't a matter of if clinicians had access to RNA testing or not, it was more of a case of even if the infant wasn't 3 months old, this might be their only chance to do the test on the infant because, for example, if they wait for 12 months, well, lots of things can happen. They can move state, they could move carer. So that was, physician's logic, I think, there.
Yeah, thanks, Grace. And another question from Alex around prescribers and whether, I know this wasn't one of the questions you put to healthcare providers, but did it come through in the discussions about whether any of them were considering prescribing, even though, even though it's not, women aren't yet eligible to be using it in their trimester, but perhaps to hold on to for use postpartum?
So no provider had, that's fine. There are a few providers who had attempted to try and initiate treatment in pregnancy based on the current evidence. But they face many challenges to that. And then in terms of treating people postpartum, yes, there definitely were success stories that providers shared in the way that they were able to re-engage clients. Or I think the common thread in those stories is that the clinician who was with the client already had a very good relationship with the clients who, for example, were their GP or became a trusted provider during the antenatal care period and then were able to facilitate that care. So, I think those are sort of lucky cases rather than what's usually happening.
I can see you nodding along, Alison. Was there some extra reflections you wanted to add there?
No, I think it's just in relation to when Grace has presented this elsewhere, you just see a lot of heads nodding in the room from people who are in the healthcare space specifically, because they can see a lot of times along the care pathways that they're like, oh, we don't quite do it like that in our hospital, or we don't quite do it like that in our local health district, or, the reason why we do 18 months, or, we recommend 3 years infant testing. Like, it's just, I was struck that when we first started this project, trying to wrap my head around how it is that different the sort of different care pathways that are used and the why. And sometimes it's like, I don't know if this is surprising to people or not, but sometimes they're like, well, why is somebody who may or may not have hepatitis C while pregnant going to go see the gastroenterologist at this hospital instead of the infectious disease specialist? And sometimes it was like, well, that's actually based on the interpreter and whether or not they need an interpreter in this particular situation. Because if they need an interpreter, the gastroenterologist doesn't want to see them. They want the infectious disease person to go through that. And it's just, so sometimes there's no harm in, I think, sometimes kind of poking at some of the guidelines and the pathways to sort of understand the rationale behind them, because I think sometimes it's like, well, what is going on here? And I was just struck when we started and continued to be, sort of amazed by just these different care pathways and why sometimes they're based on this piece of evidence over here, and this is based on this guideline over here, and this is based on a staffing issue, and this one is based off of like a local champion that's come in. It really makes you realize that this is not surprising to anyone on the call, but there's these like systems in place, but sometimes the decision is just made by someone higher up who's decided that this is like the easiest way to go. And I think what also comes through in Grace's interviews as well. And again, this will not be new to anybody on this call, but just the idea that if there's like a local champion who's like super interested in this because that's their kind of space and domain, then they take it up and they take it on. Like regardless if it's an infectious disease person who has an interest in it, specialist, if it's like an obstetrician who has an interest in substance use challenges, they'll take it on. But then obviously, as we know, that person leaves and things could potentially fall apart. I know just anecdotally as well, when we first started this project, I was speaking to a pediatrician in one of the Sydney-based hospitals, and they were like, if you could please just figure this out for us, that would be great. I'm like, there's just no way I'm going to be able to figure it out. But but they were like, can you figure out this pathway? Because the pediatrician was arguing that they wanted to come in much earlier because they're like, well, we come in at 18 months or we might come in at 3 years and we don't have any rapport with the mother or the parent at that point. So we want to come in earlier. But they've been, perhaps conflicting with the neonatologist who is then having conflict with the obstetrician, who's then like, there's just a lot of actors involved. And I think that what also has come out of Grace's work certainly is that Danielle spoke to this a little bit as well, is that sometimes when it's been presented at conferences, people will be like, well, we have a service for that. Like we have a treatment, we have a service for that. We have SUPs, we have WANDAs, we have cups, like whatever you want to call it, right? And I think what's been coming out of Danielle's interviews a little bit more is, some of those services seem to be like operating really well for some women. And then others are like, oh, this isn't really working for me. Like I'm getting, like navigating all of this is really confusing. So then I think also too, sorry, I'll just wrap up shortly, is that, now that we have this kind of information that is, specific to Hep C, because this is like a pilot study, but you can see, and this also comes out in Danielle's interviews, just also the confusion around OAT during pregnancy, post-pregnancy, what that looks like. There's just like a lot of opportunity to do a lot better in this space for women with substance use challenges. So I think now that we have this info, we kind of want to push it forward next to say, well, what kind of interventions do we think would be beneficial and where would this work well at one site? And does this mean, we bring in peer navigators or, is there another way that we can do this just to sort of create a system that's more optimal for these women?
I was just going to add really quick, that's where the focus group, the women or the people who had experiences with pregnancy and Hep C that helped develop the interview guide and everything. They had a lot of ideas about like what kind of intervention, what the intervention would need to look like. And it was interesting to hear them all kind of like just go off of each other's and like kind of just dream about this different system that would be like more caring and holistic. But
yeah, and really good point, I think, to comment on the fact that this isn't specific to Hep C only. It's a broader issue, and perhaps getting more minds on it. But yeah, once you've highlighted the issues. Danielle, I know you wanted to raise a question around family planning and ask Grace what the healthcare providers thought of that, about having those conversations with women, because I think you suspect that the women you interviewed yourself, Danielle, might have had a different perspective. So yeah, Grace, did you talk much about family planning conversations?
Yeah, so that was one of the questions actually. Do you have any preconception sort of conversations, or like what is standard in the care that you're delivering when you work with people who want to have children or who are pregnant? And a lot of the times it was similar to who's responsible for Hep C care. It was like parcel, like, oh no, that's not me. I'm an infectious disease. So like the obstetricians will definitely be doing that. And then the obstetricians like, oh, well, the GPs definitely did that because they saw them before they, in their early pregnancy. Yeah, it was, yeah, like hot potato, as Danielle commented. So yeah, and I think by and large, they're not really happening. And I think, yeah, I'll just leave it there.
It's such a power differential between like the healthcare, especially we think about stuff like OAT, and like providing this medication that helps many people live like more stable lives, like dramatically more stable lives. So you think anything that could disrupt that, or like this person and what they think of you, and if you sense there's going to be judgment around your decision to have kids, that's what a lot of the women were saying in interviews is that it's just they don't want to talk to anyone about it almost, and they wanted to just because they just expected like catastrophic thinking, and oftentimes true, like people didn't react well to them wanting to start a family.
Yeah. So we've got just a few minutes left. I'll ask a super quick one, which is a methodology question around whether hepatologists were grouped into your gastroenterologist category.
Yes, good question. So they were grouped into gastroenterologists, like how I put the maternal fetal medicine with the obstetricians.
Yeah.
Thanks for
Right.
clarifying.
All right, thank you. And also another question around recruitment. So how did you find that, both for the health providers and for the women? I know, Danielle, your women recruitment went a bit slower than you'd hoped. But let's start with you, Grace. How did you go with recruiting healthcare providers?
Yeah, I think it was much more straightforward than Danielle's experience. So we recruited, healthcare providers via email. We identified some who we thought would be a good fit and then invited them to participate. And oftentimes they wouldn't necessarily reply on the first email, but we would send a follow up, and then that's when we seemed to catch a lot more fish. So it wasn't too bad, honestly, recruiting.
Yeah, I think you really leverage networks in that in the recruitment of healthcare providers, and that seemed to be really a good way to go. So I guess you can't do that so much with the women themselves, though.
This, I think more than any other study that I've conducted interviews and done recruitment for, not that I have that much experience, but this one, the people that called wanted to suss me out a lot more. It had like a lot of questions about me. Who am I? What am I doing? Then even some people calling several times to just chat before actually agreeing to do the interview. And then a couple of people calling like even several times after. And I think some of it was maybe if they're at an inpatient residential place and it was clear that many people lacked, they had a like total vacuum of supportive people around them, like even people just to say like, oh, that's nice, good job, like just a sounding board that is not going to bring more drama. So I think that maybe that's why I was getting more calls, but it was I think because it was just so much more personal and risky. And even talking to some of the people at the NSPs and different sites, I even got lectured on one of them, like, oh, why would you do that? Like, how risky it is. I was like, and I had to explain it's de-identified. And, some people even asked like, oh, well, what are the transcripts published? Like they want to know details that just generally aren't ever asked of me. So it was just more contentious and people were more nervous, you could tell.
Yeah, really interesting. Okay, I think we might be at time now, so I think we will wrap up. But I just want to say thank you, Grace, for the wonderful presentation, and Alison and Danielle for joining the discussion, which was really fascinating. I feel like we could go on for hours, but thanks for sharing this really important work with our audience.
Thank you.
I'd also like to thank everyone in the audience for joining today and engaging in the discussion. Before we bring the webinar to a close, I'll just highlight what we've got coming up in our series. So next week we have Chloe Haynes from the University of Wollongong speaking on women's experiences of treatment for opioid dependence. And then the following week, we don't have a webinar because we have a whole day of research presentations at the NDARC annual symposium. So for everyone who's registered and might want to see a bit more about the program, you can scan the QR code there to take a peek. I think that's all we have time for today. So I hope you enjoyed the session and we look forward to welcoming you to our future webinars.